Megha, please start.
Thank you. Good evening to one and all. Indian Medical Association Medical Students Network UP welcomes you all to an event of its official podcast, Steadify. Here we present you the Hepatitis Week special workshop on the topic patient management. This event is conducted under the supervision of our patrons, Dr. Ashok Rai sir, Dr. Jain Sharma sir, and Dr. Sharad Agarwal sir. The co-patrons being Dr. Rajneesh Raj, Dr. Rahul Anand, and Tarun Sharma. Our heartiest welcome to our esteemed guest, Dr. Arvind Swamy, National Convener, IMA MSN, and Dr. Simran Kalra, National Secretary, IMA MSN. This event is organized by Sneer Sahani, Arjit Bansal, Abhinay Srivastav, Harsh Rai, and Harsh Srivastav. Our moderators being Megha Singh, myself, Shashwat Singh, Shashwat Sanket, Harshit Chauhan, and Jay Pasi. This event is well coordinated by Sakshi Singh, Akash Verma, and Vidur Rathi. In this workshop, we aim to impart some knowledge of patient management under the 5 main aspects which we all have to deal while working in our clinics and OPDs. These 5 main aspects being bioethics, prescription writing, lab investigations, medical interventions, and surgical interventions of hepatitis. We will be covering these aspects in the upcoming 5 days. Now, I would like to hand over the mic to our state convener, Dr. Rajneesh Raj, to please address Dr. Ashok Rai sir, and our state general secretary, Dr. Rahul Anand, to address Dr. Jain Sharma sir and Dr. Sharad Agarwal sir to proceed with the inauguration ceremony.
Thanks, Megha. On behalf of IMSN UP State, I would like to welcome our patron of this event and State President of IMA Uttar Pradesh, Dr. Ashok Rai sir, without whom support and guidance, it would be possible to sustain IMS. I request sir to inaugurate this event with some motivational. Sir, Ashok sir.
Okay, thank you, Dr. Rajneesh and dear Dr. Jain Sharma, Secretary IMA UP State, and dear Dr. Sharad Agrawal, who is ex-National Vice President of Indian Medical Association and patron of IMA MSN, and Dr. Rajneesh Raj, State Convener of IMA MSN, Rahul, State Secretary of IMA MSN, and Megha, Dr. Shiv Joshi, who is the Chairman of this National President of Bioethics, as well as National Convener of IMA JDN, Dr. Arvind Swamy, and all my friends, as well as you can say the dear doctors. I welcome you all in this Steadify grant event, that is workshop on patient management, organized by IMA Medical Student Network. As you know, IMA Medical Student Network is a vibrant organization of Indian Medical Association, and it's a vibrant wing of IMA UP State. I'm really thankful to Dr. Rajneesh Raj, who is the state coordinator of Medical Student Network, and Dr. Rahul Anand, who is the secretary of IMA MSN, for wonderful work done during this year. In spite of all odds, in spite of Corona, in spite of COVID and everything, they have done wonderful work. Today again, friends, I have written a mail to Honorable Chief Minister regarding your stipend issues, stipend of interns. Again, I have written a letter to Honorable Chief Minister, and I will go ahead with this later. IMA UP State is very much concerned and cautious about IMA MSN issues. I'm also thankful to Dr. Sneer Sahani, Dr. Arjit Bansal, Dr. Abhinay Srivastav, Dr. Harsh Rai for taking lead in this event as organizing secretaries, and Megha Singh, Shashwat Sanket, Jay Pasi, and Akash Verma, Vidur Rathi needs applause for their wonderful work as moderators and coordinators. In this event, IMA MSN is going to discuss important issues like bioethical aspects in clinic, writing a good prescription, sample collection, besides important issues of general medicine and surgery. Being a state chair of state bioethics, I congratulate IMA MSN for organizing bioethics seminar in the Uttar Pradesh. At last, I wish you all the best for this workshop as well as all your activities. Please energize yourself as we are going to organize more activities in future. Last but not the least, I am very much thankful to my secretary, Dr. Jain Sharma, and Dr. Sharad Agarwal, and whole team of office bearers of all wings for working day and night with me. I welcome Dr. Shiv, who is the national convener of IMA and all the speakers like Dr. Shalabh Gupta, Dr. A.K. Anuragi, Dr. Shabita Agrawal, and Ravi Kantiwari in Uttar Pradesh, who has spared their before I tell you of IMA recently, what they have done. One is inclusion of medical establishments in MSME. This is a great achievement of Indian Medical Association. Second is exclusion of medical establishment from industrial category in pollution control board. So this is again a strong act. Secondly, thirdly, all IMA members are working tirelessly day and night for the COVID-19, and our 8 doctors lost their life as martyrs. Fourthly, we are organizing seminar on bioethics also. And friends, I may tell you, all demands of IMA's UP state were considered by Honorable Chief Minister, except one, that's yours. Home isolation, private COVID hospital, increasing test facilities, all demand were achieved in Uttar Pradesh. Friends, IMA UP state is very much concerned about the members' issues, raising their voices to the government from time to time. Okay, lastly, I am very much thankful to IMA MSN, especially Dr. Rajneesh, Dr. Rahul, and all the team on IMA MSN, as well as team of IMA UP state for working day and night. Thank you very much.
Thank you, sir.
Thank you, sir. Good evening, everyone. Myself, Dr. Rahul Anand. Sorry for video is not working my side, but now I would like to introduce you, Dr. Sharad Agarwal, former Vice President, IMA, and patron of IMA UP. He has been the keen figure and the support for MSN UP from the day it was formed. Thank you very much, sir. And I would like him to speak few lines for us. Dr. Sharad, sir, please.
Thank you, Rahul and Rajneesh. Respected our UP State President, Dr. Ashok Rai, sir, Dr. Jain Sharma, our State Secretary, and all the students and all the leader of IMA UP MSN. I must congratulate to you because you are doing wonderful job in COVID also. I think this is your third or fourth webinar, which you are organizing in this COVID era. You have released a very good, souvenir also. So I am very pleased that our young generation, our future leadership, they are doing a lot of good job, lot of good work, lot of leadership. And see about the medical ethics, Dr. Ashok has already said what UPIM is doing. Dr. Ashok has already mentioned. But definitely, we are pursuing for your demand. We have written a letter, 2 letters to Chief Minister for increasing the stipend. And I congratulate you. And I have started 250-bedded super specialty hospital, and that is dedicated to COVID only. And on the demand of IMA President, Dr. Rajan and Dr. Ashok Rai, sir, I opened this and I offered this hospital for the COVID. And we are giving 25% discount to any other IMA member or doctor if they suffer with the COVID, because it's a very long treatment and it's a costly treatment. So that is again credit of IMA UP, that IMA UP, Dr. Ashok Rai, Dr. Jain, they took lead. They asked me, they convinced me, Dr. Rajan Sharma, he motivated me that you should offer your hospital for the COVID. So we have offered that on the COVID. And again, congratulations to Simran, to Rajneesh, to Rahul and all the team. And I wish all the success for this workshop. I think it will go for 4 or 5 days. So I wish you all the success and keep continuing good work, Long live IMA, long live IMA MSN. Thank you.
Also, I would like to welcome our very own Dr. Arvind Swami, National Convener, IMS Headquarters. I would like to state that Arvind has always supported MSN UP and kept his continued guidance throughout our team from the beginning. Now I would request Arvind for some kind words for our team.
Thank you, Rajneesh, for your introduction. Respected State President Sir Ashok Rai Sir, State Secretary Jain Sharma Sir, our Senior National Vice President Sharad Kumar Agarwal Sir, for the warmest presence. I would like to extend a warmest congratulations from IMA MSN Headquarters for this event and warm greetings to all panelists who will be in this session. I especially thank Rajneesh and Rahul for keep on organizing such events. All the best. Thank you.
Thank you, Arvind. Following up, I would like to introduce our dynamic National General Secretary, IMAMSN, Dr. Simran Kalra. She has always been supporting and looking through all the problems and issues. Now, I would appreciate if she speaks few words.
Thank you so much. Thank you so much, Rajneesh. And your whole team is amazing. Uttar Pradesh MSN has always been one of the strongest and best MSN teams we have ever had. And that is because of the IMA UP, Honorable IMA UP team. I respected Ashok sir and Sharad sir. It's your blessings that these students of IMA MSN UP have been working so amazing even in COVID scenarios. Since everyone has said the same thing, I would like to just show you the other side of the camera. All of us in this COVID could enjoy scenery, could enjoy nature, could sit at home, go and do a lot of other things. Everyone has so much on their plate, but IMA MSN UP chose to keep doing amazing, amazing work that they always do. And that is why I would like to congratulate the brilliant team that we have. And I'm very happy to be a part of this webinar today. Thank you.
Thank you, Simran. So from here now, I would like to give over the mic to Ajit and Megha. Thank you everyone for your support and all the best for the 5 days of complete show upcoming over hospital management with our esteemed guest speakers. Thank you everyone. Thank you, sir. Thank you.
Thank you.
Ajit, you can take the mic.
Thank you so much, sir. A very good evening to everyone. The impression etiquette gives in the life of a person, the same role bioethics plays in the life of a doctor. Even I should say, bioethics is a light of guidance for a patient to choose whom they should trust with their health. Today, on very first day of this workshop, to teach all of us that how we should proceed in clinics when a patient enters and treat them with ethics, we have Dr. Shiv Joshi, sir, who is our panelist for today's workshop. Sir is pursuing MD in Department of Community Medicine from Mahatma Gandhi Institute of Medical Sciences, Sevagram. He is the National President of Students Unit of Indian Program of International Network of UNESCO Chair of Bioethics. Sir is also the National Convener for Indian Medical Association Junior Doctors Network. Today, I find immense pleasure in welcoming Sir to speak on the topic bioethical aspects in clinics. We welcome you, sir.
Thank you, Arjit.
During the session, if any attendee has some question or doubt, they can put it in the chat box. Sir, if you like to introduce the topic first.
Yeah, first of all, I'd like to thank Ashok Rai sir, Jan sir and Sharad sir to enable the MSN UP branch to hold this esteemed educational event for every one of us here. And I'd like to congratulate Arvind Swami, Simran Kalra, who have been the source of motivation for all the MSN branches across India. And of course, it would be incomplete if I don't give the due credit to Rajneesh Raj and Rahul Anand, who are the state conveners and secretary respectively for the UP branch. And of course, the wonderful organizers of this event, the moderators for today. I really thank you all for giving me this opportunity. And today, I think we are talking about a very important issue, that is the bioethical aspects of clinics. We often see that science, medicine is pursued and perceived as a science of healing the individuals, but we often tend to neglect the art part of it. So when you see the definitions of medicine, it is the art and science of healing people. And it is more important that a person that is coming to you as a patient feels understood, feels that his or her problem is communicated to the doctor, and the doctor is interested and tries to talk to him or her, try to understand the problem, try to evaluate it, try to assess it in a way that is not only not only important or not only correct based on the science, but also acceptable to the patient when it comes to their own beliefs, their own systems. So I think that would be the main topic for today's panel discussion. And I'd like to discuss as per the questions that are put by you. I would try to answer as many of them as possible. So I think Arjit, that would be it from my side. If there are questions, I would like to take the questions in form of the question and answers.
Thank you, sir. So I think it's time we can proceed for the first question. Sir, according to you, what role does bioethics play in the life of a doctor?
Okay. I think this is a very deep question that you asked, and a very relevant one considering the today's time of pandemic. Um, According to me, bioethics is actually a way of life a doctor should live. So, like we talk about religion that every person has, so doctors should have a religion of bioethics. So it is a way of life that will help you not only become a good doctor, but also a good person. And when we talk about this philosophy of bioethics to be applied during our practice, we are talking in terms of certain principles, certain practical principles which need to be applied. And I'll try to touch each of them in a very brief way. One of them, and the most important one, is professionalism. So doctor who is ethically competent needs to be professional in his or her behavior. So what exactly is professionalism? Professionalism is everything, starting from how you dress up, when you reach your clinics, how you see the patient, how do you talk with your colleagues, how do you feel about taking cross consultations, how do you go about answering the patient's queries. Everything is professionalism. So it starts from the way, if I've ironed my clothes, I'm wearing an apron to my clinic, or I'm putting a stethoscope around my neck. That is part of my professionalism. What is also part of my professionalism is that how I am listening and how I'm trying to understand the problems which are told to me by the patient, and am I able to in a acceptable way, able to explain, able to treat that patient, whether I'm able to do that. That is also part of professionalism. The third important part of professionalism is when I'm talking to my colleagues. So am I comfortable enough in taking the view of my colleagues if I am in a bit of a confusion, like what would be a better treatment option for this patient, or how my patient is doing. Do you feel comfortable in doing that? So all these aspects are professionalism. The next important aspect that bioethics, as a person of bioethics, you should know is interprofessional team, working in an interprofessional team. So we as doctors are always required to work in a team. A doctor alone does not run the show. That is something we need to understand. We have our nurses who's there to facilitate us. The registration staff, if you're talking about the OPD, if you are a surgeon, you have the OT assistants, you have the OT nurses, you have your so many other people. If you're running a large hospital with emergency departments, you'll have casualty medical officers, attendants to take care of those people, shifting them to different wards, people who are helping with the diagnostics, that would include X-ray technicians. So apart from doctors, we are a team of lots of people who might not themselves be doctors, but without them, we cannot actually do justice to our role as a doctor when it comes to a wholesome treatment that we need to give to the patient. The next important concept of bioethics that you can apply in life of life of a doctor is cultural competency. So cultural competency might sound a bit overwhelming at first. We might not actually be able to understand, but then what I mean to say in simpler words is that whenever a patient comes to me and whenever I am hearing his or her complaints, or whenever I am trying to prescribe, we need to understand that that particular person has an entire cultural background around him or her. So that patient might be from a particular place where they have certain beliefs about vaccination. So it is possible that a young mother comes to you for getting the kid vaccinated, but she's afraid of it. She feels that vaccination might actually cause disease instead of curing it. Okay, so there might be these beliefs. There might be certain religious beliefs attached to the person's acceptance of a treatment. So there are certain people who would not accept blood transfusion. Okay, so we need to respect all these cultural beliefs, and we need to find a solution that is compatible with their cultural beliefs. So instead of discarding them as nonsensical beliefs, we need to find unique ways, uh, by explaining them, by creating awareness, by actually telling them what are the pros and cons of not doing what is required at the moment. And that is how you need to become culturally competent. You need to keep in mind that if a person denies something, he or she might be denying the treatment because of some reason, and we need to look it in that perspective of cultural competency. One last uh, uh, idea or philosophy that you need to implement bioethics in your life as a doctor is to work on your interpersonal skills, because ultimately it is all about communication. How you interact with your patient, how you interact with his or her relatives. So it is very important to incorporate uh, good good interpersonal skills, so that you are able to handle the patients and difficult situations well. So basically bioethics, I would say that it is a way of life, and it makes you a doctor people want to go to. You might not be a specialist, you might not be a super specialist, but you might be a general practitioner, but still you'll be a doctor who people love, who people would love to go to. So if you are ethical, if you are the person who listens to the problems of the patient and tries to solve them, then I think that is where bioethics plays an important role. So it is the art of practicing medicine.
Thank you so much, sir. So for next question, I would like Megha ma'am to ask it.
Megha, I cannot hear you.
Thank you so much, sir. Sir, you would like to ask that what are the 7 basic principles of bioethics which we all should follow?
Okay. Usually we are talking about 4 major principles when it comes to bioethics, which are autonomy, non-maleficence, beneficence, and justice. So these are the 4 major principles that we usually talk about. And the other 3 are usually more specific to medical ethics, because it deals with confidentiality, veracity, and role fidelity. So you can call it 7 principles, but I would usually say that there are 4 principles, 4 core principles of bioethics, which are autonomy, which means that we need to respect the decision of our patients. We need to understand that we can facilitate the decision making, and we don't have to take decisions for them. Okay, so we need to respect that decision making process. We need to give that stick in hand of the patient so that they decide for themselves. At the same time, the important concept in autonomy is regarding informed consent. So it was that moment when people started talking about informed consent that autonomy became very important in the field of bioethics and in the field of healthcare by large. The second principle that we talk about is non-maleficence. So it is like do no harm. But then I've often heard people saying that, like, of course, a doctor never intends to do harm. So वो कभी घर से सोच के नहीं निकलेगा कि today I'm going to go and kill a patient. Okay, so that is never a thing. But by what do I mean by do no harm? there will always be some level of side effects, some level of unpredictable things that will happen during our practice as a medicine, because medicine is not a perfect science. So when this happens, we need to understand that we have to weigh the benefit and harm. So not in a single instance, it should be a case that the harm outweighs the benefit. If your treatment is affecting more in terms of side effects as compared to the solution or the treatment that it is able to give, then I think we need to reconsider that treatment. We need to see that the benefit always outweighs the harm. That is the second basic principle, that is non-maleficence. The third principle is beneficence. So beneficence is very much complementary to non-maleficence. We need to see that the intervention or whatever the procedures, even if these are the lifestyle modifications, whatever we are trying to convey to the patient should benefit them. We need to make sure that the patient stays healthy. So treating his illness, his or her illness is one part, but to ensure that the patient stays healthy is more important. That is where the principle of beneficence comes into picture. The fourth principle that we usually talk about is justice. So if you actually go through the literature, if you try to look at the different healthcare systems across the globe, we see that there are lots of health disparities. Even within the nations, we usually see that different states, there is lots of health disparities. People don't have access to healthcare. People don't have access to medicines. There are lots of issues. So when we talk about justice, the justice, a good example would be what? So I have a treatment in my hand, and now I have two patients, and one patient is able to afford it because the patient is rich. Another patient cannot afford it. Okay, so just mere absence of money or mere presence of a higher or a better socioeconomic status of a person should not entitle them to a treatment and take away the treatment from the other person. Okay, so that would be unfair, right? Just because I don't have money, I don't get the treatment. That would be unfair. So the principle of justice says that if there is a treatment, if there's an intervention which is going to help the person for sure, but it is certain non-modifiable factor that is affecting them and they're unable to access this treatment, then we need to make sure that there is a level of assessment where you see whether the patient's illness is severe enough to get the treatment, or whether giving the treatment to a particular patient is going to save their life. It needs to be based on that and not on the basis of whether the person is able to pay, whether the person is able to convey to us if there are other ways to pay back. Those things can be there. So justice is the fourth principle. But then when we talk about practice, there are three additional principles that we usually discuss about. One of them is confidentiality. And most of us know what is confidentiality. And there are these two terms, privacy and confidentiality, right? So privacy pertains to the consultation that we are having. So having an environment where the patient is able to speak freely to me, that would mean privacy. Keeping this consultation something that is between me and my patient, that is confidentiality. Okay, so there's a very small difference between privacy and confidentiality, but it is important to maintain both. The next one is role fidelity. That would mean that we should always be practicing within our scope. So let's not try, we should always know what is our training and what are the diseases, what are the conditions we are able to cater to. And we should practice in that, in that scope only. So a general practitioner, depending on his or her training, if they have the training for doing MTPs, they should do MTPs. But if they have never done MTPs, they cannot experiment or they cannot try doing MTPs. Okay. If they have an experience of doing a hernia surgery, fine, you might debate that a hernia surgery should be done by a general surgeon. Not necessarily. I won't agree to that. I would say practice within your scope. So a general practitioner who has done observership, who has done training in doing hernioplasty, can do hernioplasty. All right. The idea is that we need to practice within our scope. So whatever training we have got, we will practice only in that area. We won't be practicing outside of it. Okay, we will stick to our limitations, we'll stick to our strengths. Okay, so that is what we call as role fidelity. Okay, and the last principle, the seventh principle that we usually discuss about is veracity. And veracity usually deals with truth telling. So how much of the truth I'm telling to my patient, or what is the truth about the disease that I convey to my patient. And this is a bit tricky. Why I'm calling it tricky? Because there is a concept of nocebo effect. So I am sure every one of us has heard of a placebo effect. If you have heard, please put a thumb. Okay, so quite a few of you have heard of placebo effect, right? So we are not actually giving a drug to anyone, but still the patient sees improvement, or still the patient sees an effect, right? That is placebo. But then there is a concept of nocebo effect. Okay, so nocebo effect says that if I am telling the entire truth to the patient about his or her condition, it is possible that the patient gets more harm than benefits. Okay, so that is this concept that we usually discuss, and it is called as nocebo effect. So how much of the truth needs to be told, that is still debatable. So should we tell the patient about what is the expected life that is remaining after he has got a particular diagnosis, or should we tell him that there's nothing more we can do for you? So there are lots of gray areas when it comes to bioethics, and this is one such gray area. How much truth to tell? But truth telling is one of the important principles of practicing as an ethical doctor. Those are the seven principles, four principles of bioethics, and three which are usually used in context of medical ethics.
Thank you so much, sir. So the next question is, please explain bioethics according to a doctor's-patient relationship, and especially a special thing on in these COVID scenarios, that if a person is coming coughing, so how a doctor should react, how he should treat him.
Yeah, I think it is a very relevant question because considering the pandemic that we are in middle of right now, and okay, so what I'll do with you is a practical approach. Okay, not something that is a philosophy. This is something you can implement in your day-to-day practice. So one important critic of bioethics is that it is a very philosophical subject, and not practical, and we just discuss on things, but it is not implemented in our routine practice. So here I'm going to suggest you a technique which is called as the gather approach, and I would like each one of you, if you are an intern or if you are a resident, and you will be eventually, even if you are medical students right now, so I would like you to consider this particular approach, and this approach is called as the gather approach. Okay, and when you are the key to your doctor-patient relationship is your rapport. Okay, so your rapport building in those small amount of time, that those few minutes that you have with the patient, because of the OPD load, and there are lots of patients. You have to see lots of patients in a very limited time. There are less resources. So in such a condition, how do you actually implement bioethics? That is a challenge. So I'm going to give you a very quick way, and in those 5 minutes that you have with the patient, you can actually implement this. Okay, so it is called as the gather approach, GATHER, and each of these alphabets stand for a technique. Okay, so we'll begin with the G, that is greet. Okay, so whenever the patient comes, so right now if I'm sitting in my OPD and if a patient comes, I need to greet him or her. And greeting doesn't mean that I have to do something, very odd. Uh, I might just be smiling at them. Okay, come, have a seat. That is a form of a greeting. Okay, saying maybe namaste in the local language is a greeting. Hello, if the patient is young, you might just want to smile and say hello. If the patient is a baby, you might just want to, give your hand to the baby, and a sort of a greeting, some sort of a greeting. It can be verbal, it can be non-verbal. Okay, but you need to greet them, and that doesn't take much of your time. It will hardly take you a second to smile. It will hardly take you a second to say, please have a seat, right? These are very small things. So you should start with a greet. The A is ask. So whenever you are asking about the problems that the patient has come for, it is very important that you ask them the problems in their own language, and you ask them in a very friendly manner. Okay, so let me give you an example. So a patient comes to me and she says, I'm deliberately giving an example of a she, of a female, because I want to emphasize on some points through this example. So a female comes to my OPD and she says that, sir, I'm having back pain. All right. So I'm like, okay, back pain. And I automatically start assuming that, okay, she's a young female. She might be doing lots of housework, and she even might be newly married. So she's having all these psychosomatic complaints. So I just give her a painkiller and let her go. That can be one approach, right? But what we might actually miss is that because I was not having a rapport with her, because I did not greet her when she came, she was not feeling that she can share her complaints with me openly. She actually did not mention her chief complaint. Okay, that is quite possible. So her chief complaint in this case might be white discharge, and because of which she was having back pain, low back pain, right? We might have entirely missed that. She might have certain menstrual complaints. We might have, completely missed them because we never felt to ask the complaints in a bit of a detail. At least few more things. कब से हो रहा है, क्यों हो रहा है, मतलब कब से हो रहा है, how was the onset, do you think you were hurt by something, right? Few questions जो हम routinely हमारे negative history के part में पूछते ही है. Can we ask those questions in a more friendly way, in a way that is acceptable, एक friendly environment create हो. So I can just maybe ask that, okay, आपको ये दर्द तो हो रहा है, but then आपको इसके साथ और कोई तकलीफ है क्या, आपको पेशाब में जलन हो रही है क्या, and you need to normalize these things. Okay, so when you are asking her such questions, these need to be in a friendly way. So don't make a very serious face and like make them intimidating, and she might just get scared and she might not tell it to you. Same might happen with a guy who is talking to a female doctor. All right, he might have a scrotal swelling, hernia, or a hydrocele, and he or she might not be able to explain it well, and he might just say that I have lower abdominal pain. Okay, so ask your questions, ask your history in a friendly manner. Whatever 2 minutes you are giving it to them, but just make sure that you keep a smiling face and you are trying to listen to their complaints and not just hearing them. Okay, that is the A. T is the tell point. So you need to tell the patient the relevant information. Okay, so once I hear the complaints, whatever they have to say, I'm going to tell them what I feel in the language that they understand. Okay, so if I think that it is hernia, okay, and if I say that आपको hernia हो गया है, it doesn't make sense to them. Okay, if it is a very common condition, it is a different thing, but some conditions might not be so common. So you might have something called as varicose veins. Okay, the condition is common, the name varicose veins might not be that common, right? So you just told them that आपको varicose vein है, तो आपको अभी surgery में आके intervention करना पड़ेगा. Now see, the terms that I'm using is varicose veins, surgery में आपको इलाज करना पड़ेगा. See, patient immediately gets panicked कि बाप रे क्या हो गया मुझे, है ना? So it is very important that you tell them, you talk to them in their own language. Okay, so instead of saying मुझे varicose vein हुआ है, कैन वी जस्ट से कि काका कुछ नहीं हुआ है, आपके जो नीचे में जो नसें होती है वो हल्की सी फूल गई है ना? सो इट बिकम्स अ बिट ऑफ अ लाइटर सिचुएशन. द पेशेंट इज इन अ मूड टू अंडरस्टैंड further about it. Okay, you can, if you have time, you might even let them know that why this is happening and you should not worry about this. It is treatable. इसके लिए ऑपरेशन लगेगा. अगर ऑपरेशन यूज नहीं करना है तो आप टाइट सॉक्स पहन सकते हैं, है ना? बट देन द थिंग इज दैट you need to tell them in a language that they understand. Okay, and not the medical jargon that we are used to. All right, the next one is help. So after you have asked their problems, you have told them what they need to know, help them to make a decision regarding their therapy. Okay, so you have those 1 or 2 minutes where you are quickly writing the prescription, right? At the same time, as doctors, you are also expected to write the advice section of your OPD prescriptions. Okay, so you are writing the drugs, but what about the advice that you are going to give them? So is there an advice that I can give to a patient of varicose vein? Can I ask them to do limb elevation, right? These are some very small things which we usually forget. We are more focused on how to treat it using drugs, surgery. But what about those common, simple lifestyle modifications that anyone can do? Something that is free for them. They don't have to pay for it, right? They don't have to pay for the for doing for going for a run in the morning for 20 minutes. They don't have to pay for limb elevation, right? But they'll have to pay for the medicines that you are writing to them. They'll have to pay for the physiotherapy sessions that you are advising to them, right? So we also need to focus on that part and help them choose and select between these methods to make an ideal combination of these techniques, so that the patient is able to use them to treat their condition in a more sustainable way. This is basically more helpful when we are talking about non-communicable diseases, and when there are, a lot of diseases like hypertension, diabetes mellitus, which require a very long-term treatment. And in that, you really need to help the patient to take the right decisions about their food, about their treatment, about the time of medications, about how they are eating their food, the timing, what they need to prevent, what they need to restrict in their diets, everything. So you need to help them make those decisions, okay? But never take their decisions for them. So you are not going to take their decisions for them. You are going to help them take a decision. Okay, there's a difference in that. अगर मैं उनको कह देता हूँ कि आपने इसको ऐसे करना है, so that is like I have taken a decision for them, which is not good. That is not something an ethical doctor will do. I'll tell them that this and this things, if you are doing, these will be the advantages. So it would be really good if you do it, okay? And you help them take that decision. All right, that is how help works. E, gather ka jo E hai, E is about explain. So after you have told them about the condition, what they have, and after you have helped them make a decision, you need to explain it to them about, like, that can be regarding the intervention that you just told them. It can be regarding the condition if they want to know anything more about it. Okay, so you need to explain it. And R is for return. So return to the patient and ask whether he or she has understood everything that was told to him or her. Okay, if not, now is the time to ask for any clarifications. So you return to the patient to ask if they need any clarifications, and that would be how you'll be ending your session. And believe me, it looks like a lot, but if you start doing it regularly in your practice, in your daily consultations, it will become a part of you. It will be something you don't have to emphasize on. You don't have to, look forward to it. It will just happen. It will become your habit. And then those 5 minutes will be enough to implement all these things. All right. So I think that can be one practical approach when it comes to building up the doctor-patient relationship. Because rapport is the key, and this gather approach is going to help you build that, and the patient will also come for good follow-ups. There will be better compliance to the therapy. That is what I feel.
Thank you so much, sir. We will surely apply this gather approach in our upcoming clinical practices. Sir, next question we would like to ask that what are the repercussions a doctor can face if he or she is not following the bioethical laws?
Okay, I think there's an important clarification needed here. When we talk about bioethics is not a law. Okay, it is a guideline. Okay, it is something that we are expected to follow as doctors, but if we don't follow, no one is going to penalize us for not following. So if I don't greet my patient, no one can put me in jail. Okay, if I don't explain it to them the treatment, but I have written them the prescription, so no one is going to put me in jail for that. Okay, but then there is a difference. There's something called as professional misconduct. Okay, so if you breach your guidelines that are determining your professional behavior, if you breach those guidelines, you are not a criminal, but you are definitely a part of professional misconduct. So in your own community, you are not that welcome if you don't follow these bioethical guidelines. Okay, second important thing is that your attitude or your misconduct might be perceived by others as medical negligence. Okay, so you felt that greeting is not important, maybe assessing is not that much important, and so that those are your perceptions as an individual. But because you did not do it, somebody felt that it was an act of medical negligence. Okay, that comes under the purview of law. So your habits are going to make you a good doctor and a bad doctor. So if I'm used to see my patients in a very ethical manner, in a way that is acceptable to them, in a way that is decent, in a way that is polite, humble, in a way that is acceptable, then I am keeping myself away from medical negligence. Okay, and even if I do medical negligence, there is very high chance that my patient will, you know, just let it go. Okay, कि ये डॉक्टर अच्छा है, इससे गलती हो गई होगी, right? There is a higher chance. Today, when we see that there are lots of cases of violence happening, bioethical, though it is a guidelines, though it is just a guideline and not a law, it becomes very important to follow these principles. That actually gives you an additional layer of protection from your patients, because they will try to see the good that has happened to them during their routine consultations, and there are better chances of avoiding a doctor-patient conflict. So that is there. One important aspect that I should mention. So, profession, you all might be aware, medical negligence is part of 304 IPC of Indian Penal Code, 304 IPC. So it is part of that. So medical negligence is a legal problem, but not following the bioethical guidelines is not legal issue. It is more of a misconduct. It is thought of as a misconduct, and you won't get any jail or any legal implications for that. But those habits might actually sometime down your life, it might transform into medical negligence. So that is possible. There's something called as conscious objection. Okay, so right now we are saying COVID ke daily or weekly, there are lots of change in guidelines that come across. Okay, so does the doctor have that authority to consciously do something else apart from what is written in the guidelines? That is called as conscious objection. So doctor can take a conscious objection, but it needs to be backed up scientifically. So I might choose not to give hydroxychloroquine to my patients, but if I'm not giving it, then I need to back my decision with the acceptable scientific evidence. If I don't do that, my conscious objection might actually be considered as a medical negligence. All right. So these are certain intricacies of the things that I'd like to share. Yeah.
Can I ask Arijit to please proceed with the next question?
Thank you, sir. With your experience, please throw some light on breaking bad news. I think this is a major problem these days some people are facing.
Yeah, of course, a patient is COVID positive. So how should you go about it, right? It is a bad news, definitely a bad news. From my experience, again, I prefer giving you a very point by point approach because I feel that bioethics is a practical approach. So what I'm going to do for you is I'm going to give you 6 steps. Okay. I'm going to give you 6 steps. And if you can apply this while breaking the bad news, I am pretty much confident that 95% of the times you might be able to prevent the conflict. Then at some time, see, things are not always in your hands and things might just go in the wrong direction. So yes, of course, there might be those issues. But then if you follow this, I think 95% of the times you would be able to prevent any, episode of panic in the patient or their relatives. That is what I feel. So these steps go like this. Whenever there's a bad news that you need to break, you start with the preparation. Okay. So you prepare your reports well. Okay. Before breaking the bad news, just don't go in front of the patient and like an accident, you just tell them, "Arey, tumhara ye positive hai, you are this." Okay. See, just imagine if someone does that to you. Okay. It is shocking. It is surprising. It is overwhelming. It is, it shakes that person from the inside. So it is something which is normal for us. Giving that diagnosis might be normal for us, but for that patient, he or she is hearing it for first and last time in their lives, and it is happening to them. So it is a very big deal, right? So always prepare, make them comfortable. So whenever you are going to disclose a bad news, it is always a good idea to ask them, come sit in your cabin and you discuss with them in a place where they feel comfortable. Okay, so they might feel comfortable in their own private ward. Okay, so go there and talk instead of calling them in your cabin. Okay, so there needs to be that change in approach. Okay, so prepare, always prepare and make them comfortable first. The second step is set the environment or the context. Okay, so before actually you enter into this conversation, it is always better to set a context scheme. You have been, doing so well in this, and it is really good to see that you're following all your treatments. Such a context that, okay, so the patient will automatically come to understand that the doctor has come to talk to me, and he or she is using such language. So there's something that is, coming up. Okay, so something has happened and something is coming up in my report, has come up in my reports. So it might be serious, right? So एक अंदर से mental preparation patient की तरफ से चालू हो जाता है. Your third step should be build up. Okay, so now this bad news, instead of breaking it as a whole, okay, break it up into smaller parts. Okay? Make that bad news a little bit more digestible. Okay, so what I'll usually do is, if I am supposed to give this in like a diagnosis of COVID-19 to my patient, what would be my approach? My approach would be, I'll tell them कि काका आपको इतने दिन से खांसी था, आपको बुखार था, एंड आप समझ रहे हैं कि अभी जो टाइम चल रहा है ये कोरोना का पैंडेमिक है और बहुत सारे लोगों को इससे प्रॉब्लम हो रहा है. इट इज रियली गुड कि आपने आपने एकदम प्रॉम्प्ट आपने एक्शन लिया, आप तुरंत हॉस्पिटल दिखाने आए. बट टू माय सरप्राइज एंड आई एम रियली सॉरी कि आपका जो टेस्ट का रिपोर्ट हमारे पास आया है, इसके अंदर जो लेवल्स हमें दिख रहे हैं उस हिसाब से शायद आपको एक नया इन्फेक्शन अभी रिसेंटली हुआ था, एंड दैट is a COVID infection, but it's fine. Okay, so the moment I say it's fine, I go to my fourth step, that is normalize. Okay, so normalize it. Okay, don't keep on saying it again and again, and to emphasize that it is a very big disease, instead you immediately normalize it. So the moment I've built up this and I've told him finally that you have COVID-19, immediately what I'm saying is that but it's okay, it's okay. काफी लोगों को ये हो रहा है, and you look at the recovery, बहुत लोग recover कर जा रहे हैं, है ना. और आपको तो as such you are a strong person, it is possible आपको और कोई comorbidities नहीं है इतनी ज्यादा, आपको बीपी शुगर का प्रॉब्लम नहीं है, तो आपके चांसेस बहुत अच्छे हैं, है ना. तो you don't have to give hope, right? So you need to immediately normalize the context. You need to normalize that context कि कुछ बहुत बड़ा नहीं हो गया है, it is fine, it happens to many people, and but you cannot say that. So आपको ऐसा नहीं बोलना है कि ठीक है आप टेंशन मत लो, बहुत लोगों को होता है. If you say in that language, it becomes offensive. Okay, but you need to normalize it. That Kaka, though I'm really sorry I have to break this news to you, but it is fine. People have recovered from this, and we will try our best. So you immediately normalize it. Okay, after you normalize it, you go to the fifth step, that is mention their options. Okay, so what are the options that they have now that they have this COVID-19? Okay, so what are my options? What are their options? Now see, to give them those options, I need to be knowledgeable first. So if I know entirely about the disease, only then I can give them the options. So that is very important part, and that is somewhere our training comes into picture. But then when you are telling them, you need to mention the options of treatments, those are available, what level of facilities are available for isolation, the HDU facilities, and how they'll be taken care of very nicely in those HDU. There's nothing to worry about. People will be there inside HDU. They'll take care of you. And there are these options. So you can go either in the civil hospital and get yourself registered, or you can go to this particular hospital and you can get yourself registered. It will be usually a 14 days time. We might see certain improvement, but let's not rely much on those figures, because if we don't want to give very, very short findings to them. अगर हमने बोल दिया 14 दिन में आप ठीक हो जाओगे, तो 14th day को that person will again have a hope. Okay, so you should not do that. It is always better to keep that possibility in mind that 14 दिन के आसपास लगभग इसको लगता है, but जरूरी नहीं है कि इतना ही लगे, हो सकता है कि ये ज्यादा लंबा हो जाए, है ना. Because we don't want them to believe that nothing can go wrong. Okay, because if you make them believe that nothing will go wrong, in that case, if you make them believe that nothing will go wrong, in that case, if something goes wrong, then you will be blamed. Okay, so that is very important. In the last, you help them select the best option for them. Okay, so the sixth step after mentioning all the options, you should help them take the best option out. So you might tell them that आपका घर यहीं पे है तो आप वहीं पे चले जाइए, है ना? अच्छा रहेगा, आपका कम्युनिकेशन, आपका सारा आपके फैमिली उसी जगह में रहते हैं, सो दो आप उनसे मिल नहीं पाएंगे बट शायद आपको बात करने का कुछ अरेंजमेंट कर सके हॉस्पिटल, है ना? इस तरह से यू नीड टू हेल्प देम सिलेक्ट द बेस्ट थेरेपी, द बेस्ट ऑप्शंस. So I think this is my experience. This is a strategy I usually use while breaking the bad news, and I think it has always helped me. Fingers crossed, but I have not faced any incidents of violence. When I was breaking a bad news. So I think if you follow this, most of the times it will be good. Sometimes things won't be in your hands and it might go the other way. But I think in such cases, none of us can do anything. So yeah.
Thank you, sir. Sir, we would like to ask you that although euthanasia is banned in India, but what we can do if, as a doctor, we can do if the patient's relatives ask for euthanasia?
Okay, so there is actually a one-line answer to this. You do not give euthanasia. Okay, in our country, active euthanasia is banned. Okay, so whatever they say, whatever the relatives say, however sorry you feel for the patient, please never give active euthanasia. It is banned in our country. Okay, do not get emotional. Take a professional decision then. Okay, but this brings me to if I remember it correctly, it was in March 2018 that there was a hearing in the Supreme Court. The case was filed by Pinky Virani, and it was the famous, I should say infamous, Aruna Shanbag's case. Okay, and in that case, there was a landmark decision by Supreme Court of India, Honorable Supreme Court of India, and they said that the passive euthanasia is possible. Okay, so though you cannot actively give euthanasia, there is a provision for passive euthanasia, but there are strict legal entities surrounding it. So if there is a passive euthanasia that is to occur, then a doctor has to certify that the person is going to stay in that persistent vegetative state for rest of their lives. Also, the patient's consent is important. If they can speak, they have to write a will, consent in form of a will. Okay, that they allow the doctor to give them the passive euthanasia, because these things are there to protect the interests of the patients, and we don't want people misusing this. Okay, so I think euthanasia legally, if you say, there are many more things. There are findings from this case which are very interesting. You should all read about the Aruna Shanbag's case. If you don't know about it, which I'm pretty sure you all know about it, but if you don't know about it, and if you need to know more about that Supreme Court judgment, I'll leave my email in the chat box. You can write to me and I can share certain documents with you, which might help you better understand what is the stand of passive euthanasia in our country. Yeah. So I have actually left my email in the chat box. So if you have any other queries which are not covered in this session, and if we have some time, of course, we can take it right now.
Arjit, please be presentable. Yeah.
Thank you so much, sir, for sharing such a great knowledge. I hope our audience have learned a lot from this and follow these ethics in their clinical practice and future. So there are a few questions from audience side. If you allow, so can we proceed?
Yes, please go ahead.
So our first question is, can we prescribe by text or mouth to relatives in internship or post MBBS?
Can you prescribe?
Can you prescribe anything by text or mouth to the relatives in internship or post MBBS?
Okay, okay. So see, this is something that requires a legal understanding of how your licensing works. Okay, so before you are licensed, okay, or at least provisionally registered with your medical council, you are not allowed to write prescriptions. Okay, so even if you have qualified your final year, you cannot write the prescription, but as interns, you can write prescription under the supervision of a permanent of a person who has a permanent registration. Okay, so under their supervision, an intern can write, because all the interns before starting their internship are provisionally registered with their respective state medical councils. So once you get your provisional license or the provisional registration is done at your state medical council, you can write the prescription. But till you have got your permanent registration, you need to write that under the supervision of either a postgraduate student or a consultant. Okay, so that would be the answer.
Thank you, sir.
And
So the next,
next question we would like to ask, that is it okay to be fully truthful to the patient even if it shocks to him?
Okay, so this is exactly the point that I was mentioning previously about the nocebo effect. So there is a very good article on this, and I can share it to you if you write me on the email. But the article goes like this, that they did a study and they found that people who were told in entirety about that particular disease, uh, they survived less because their hope was lost. Okay, they did not have hope to survive because they were clearly told that they were told everything about the disease. Okay, as a usual practice, हमारे consent में everything was mentioned that now that you are admitted in this palliative care ward, there is most likely there is no other treatment that you can obtain, and you are in the terminal phase of the disease where death is an impending thing. Okay, so when I am telling my patient clearly that there's nothing more I can do for you as a doctor, you actually kill that patient's hope, their strength to survive. Okay, and that is where the bioethics come into play, of how much to share. Do we really need to tell them that there is no hope for treatment? Okay, you need to tell them regarding the options, of course. You need to tell them regarding their condition, of course. But do you really have to say that there is no treatment for this? Okay, so that is where the role comes about contextualizing your statements. Okay, so if there is a patient of cancer and if he or she is dying, I might say that there are certain treatments available, but they remain expensive. Okay, so in a way I'm conveying that, dude, the treatment is expensive. Patient, I'm telling it to them that the treatment is expensive and you might not be able to afford it, and somehow this hospital cannot provide you the treatment. But I'm not saying that explicitly that now nothing can be done, everything is lost. Okay, so that sort of scenario needs to be avoided. So you need to keep your information that you share with the patient context specific, uh, depending on what and how much the patient needs to know, how much they want to know. You should progress. So if the patient is okay, if they are saying that I can handle the truth, you please share with me the entire thing, and then if you proceed, that's okay. But if the patient doesn't want to hear the entire truth, then you are legally or morally bound to tell them the diagnosis and what are the treatment options, and if they want to take those treatment or not. Otherwise, you as a doctor are there as a facilitator. You need not overemphasize on very elaborate explanation of their condition, which might actually overwhelm them, and they might feel that there's nothing more that can be done in their case. They might feel hopeless. So that should not happen.
Next question we would like to ask, that what should we do when patient relatives attack us? As we can see that violence is prevailing against doctors. So what will be the thing we can do for it?
Okay. See, again, to this, I would like to answer it in a context. There are two contexts. Okay. First, we need to think whether this violence has happened by a person and their relatives who were taking treatment since a long time at my hospital, or whether this person has come just now. They have never visited my hospital. He or she is not my patient. Okay. So that context is very important, because if that patient was taking routine care at my own hospital and now they have some issues, then I'll be in a better position to address them. But if they are entirely new patients whom I don't know, I'm seeing them for the first time, and they come to me and they start attacking me, then the situation becomes a bit out of hand. But again, I would like to say that there can be strategies, okay, that you can still try to employ. Every time it will work, I cannot guarantee as a human, but then what I can say is that most of the time it will be fine. uh, and coincidentally, it was just today morning that three people came to my OPD, where I am right now, and uh, there was a case of neurosurgery. So there were three people. They came to my registration desk here in the OPD, and they started abusing the sister who was sitting there, who was registering the patients. Okay, so they started saying that आप लोग डॉक्टर्स देख नहीं रहे हमारे पेशेंट को, हमारा पेशेंट इतना सीरियस है, and and that person was really, you know, genuinely he was shaking. So he was very angry when he was talking to the nurse. So immediately क्या हो रहा है, we were all sitting here, and sister came to us, and now we had to handle that situation. Now see, what has happened was, when I went there, the patient was shouting, okay, but I did not shout. Okay, I just asked them that, okay, ठीक है, आप मुझे ये बताइए कि आपका पेशेंट कहाँ है. ओके, सो ही वाज अगेन शाउटिंग कि मेरा पेशेंट जब से घूम रहा है, बोले हमने अभी उसको 26 नंबर के ओपीडी में दिखाया है, वहां पे कोई डॉक्टर नहीं है, वो ओटी में गए हैं. ओके ओके फाइन, ठीक है, you do not react to that. Okay, do not react to that. Then you ask them for their card, OPD card, because you still don't know what exactly the situation was. So now I was caught up in a situation where I didn't know that patient. It was not my patient whom I was seeing through my previous visits. Okay, it was a new patient. Okay, so मुझे उसके बारे में कुछ भी नहीं पता था. So now you take their card, you try to see what exactly was written on the card, and then you come to know, I came to know that the patient was a patient of psychiatry. Okay, and he was advised a neurosurgical opinion, but the patient is very irritable, not feeling well, and the relatives are very panicky because from someone from neurosurgery OPD told them that we don't know when the doctor will come, when the neurosurgeon will return. So 2 घंटा भी लग सकता है, 4 घंटा भी लग सकता है, आपको बैठना है तो बैठो, नहीं तो जाओ. Fine. So when such sort of communication happens, then the problem starts. Because now what happens is that the relatives and the patient, they lose trust in you. They feel that they are on their own. Okay, but the moment you take their card and try to explain it to them as a third person, because see, I was not involved in neurosurgery, so I was sitting in my OPD, right? So the moment I started explaining him what has happened, the moment I told him what was written in his card, the moment I explained him why the neurosurgeon was not there at this OPD, his voice became low. Okay, because he started getting some answers that why this was happening with him. Okay, so I think what is the most important part of avoiding the violence is that you communicate to the patient and the relatives at as many levels as possible. Okay, so if the patient is taking long-term care at your hospital, you make sure that right from the day of admission, you keep on informing the patient as well as the relatives about the condition, how it is progressing. Okay, because you feel that you will be managing everything, or फिर 2 हफ्ते बाद you see that now the patient's prognosis is very bad, and you then go after those 15 days and tell them that patient has deteriorated and the chances of survival are very low, then they immediately will react. Then फिर इतने दिन से आप कर क्या रहे थे, right? So that is how the problem starts. So that you need to prevent. Okay, so at least जो long term care में आपके patients हैं, उनके साथ तो violence के cases होने ही नहीं चाहिए. ठीक है, unless and until it is a very different thing, politically powered है, there are other vested interests, vested agendas, then it is a different thing. You cannot do anything in those situations apart from filing a FIR after the violence has happened. Okay, but then most of the times patients are just patients, normal human beings trying to get some sympathy for their condition, just trying to get your attention because you are the doctor and you're everything for them in that moment. So I think we need to appreciate that particular emotion that they have in that moment and try to respond to that in as calm manner as possible. Agar patient ekdam naya hai, if you have never seen them, then try to understand what is irritating them. Okay, and if you cannot, if it is not in your hands, clearly tell it to them. Don't try to become a hero there, saying that हाँ patient को अंदर लीजिए, हम देखते हैं हम क्या कर सकेंगे. If you know that that patient is not going to get any services in your hospital because there are not the provisions, please make it very clear to them दैट सर मैं आपका पेशेंट अंदर ले रहा हूँ, मैं इसको सिर्फ बेसिक ट्रीटमेंट दे पाऊंगा जो मेरे हॉस्पिटल में अवेलेबल है, बट इसको बाकी ज्यादा ट्रीटमेंट लगेगा, हाई लेवल का ट्रीटमेंट लगेगा जो मेरे हॉस्पिटल में नहीं पॉसिबल है, मेरे हॉस्पिटल में उसको देने के लिए कोई और ट्रीटमेंट अवेलेबल नहीं है, तो आप प्लीज इसको जल्द से जल्द दूसरे हॉस्पिटल में विथ रेफरल, प्रॉपर रेफरल यू शुड सेंड। तो यहाँ पे at any n number of cases if you look, the problem is in communication. Either the doctor has failed in communicating what exactly was happening to the patient, or the relatives have failed in communicating what their problem was. Okay, so try to identify, try to communicate, and most of the times you'll be able to uh, solve the problem and there won't be any violence. So those people, I was able to solve that problem. ठीक है, ये कोई इतना बड़ा problem नहीं था, it was just related to OPD consultation, but it might be very serious sometimes. Okay, किसी का डिलीवरी हो सकता है and a doctor is not available. सब सेंटर की बात हो सकती है जहाँ पे एक लेडी को आप लेके जा रहे हो बट वहाँ पे नर्स अवेलेबल नहीं है, अब उसकी डिलीवरी कौन कराएगा, इट माइट बी समथिंग मोर सीरियस, राइट? बट देन फॉर ऑल these things you need to make sure that you communicate as much as possible, and sometimes things will go wrong. I cannot say that every time it will work, but most of the time it will work and you'll stay safe. That is what I feel.
Thank you, sir. So there is a last question from audience side. Many times it happens that patients refuse to take the medicine and being very reluctant to it. Maybe because of the patient being brainwashed or other reason. Then what to do in that cases? How to counsel?
Okay. See, now this is something that you face almost daily in your clinics, that you'll find at least 1 or 2 patients coming to your OPD whom you have given the treatment, but they just won't comply with it. ठीक है, एक most common जो हम देखते हैं, it is in cases of tuberculosis. Okay, so once you start them on the anti-tubercular treatment, they take it for 15-20 days and then they leave it. They just don't take it for the rest of the time. But then, you know, why this is happening? We as a doctor, if you come across such a patient, there are 2 ways a doctor tries to handle this. One is threat. Okay, so threat वाला system क्या है कि आप उसको कहते हो कि हाँ मत लो, आपको लेना नहीं है ना, आपकी बीमारी बढ़ जाएगी, you can even die, why are you doing this, आपको इतना समझ में नहीं आता क्या, आपके 30 गोलियां खानी है 30 दिन की, इसमें क्या समझने वाला है, आपको समझ में नहीं आता. So one is the game where you are going to blame that patient that he or she is not taking the drug. Okay, the moment you do that, again, normal human psychological defense mechanism, the moment you say this, the patient loses trust in you, your rapport is gone, and the entire discussion goes in a different direction. Second way, which is a better one, can be to actually try to understand that okay, आप ये treatment नहीं ले रहे, कोई कारण है क्या, है ना, कोई कारण है क्या, आपको टेस्ट नहीं पसंद आ रहा है क्या, आपको क्या इश्यू है, आप क्यों नहीं ले रहे हो, है ना. सी नाउ स्पेसिफिकली दिस हैपेंस विद आयरन टैबलेट्स. सो किसी को सीवियर एनीमिया है, आपने उनको आयरन टैबलेट्स दी है, बट नेक्स्ट डे क्या हो रहा है, patient is having black stools, constipation, so she starts feeling कि पता नहीं, मुझे तो कुछ तकलीफ थी नहीं, मुझे कुछ तकलीफ थी नहीं, मैंने ये वाली गोलियां चालू की और मुझे अभी पता नहीं मेरा स्टूल का कलर चेंज हो गया है, मुझे कॉन्स्टिपेशन हो रहा है ना. और यू गिव देम डाइक्लोफिनेक एंड इट कॉज देम गैस्ट्राइटिस, राइट. तो दे वुड इमीडिएटली रिएक्ट टू इट कि ये कैसे डॉक्टर है, मुझे गलत दवाई दे दी इन्होंने, है ना. दिस थिंग्स कैन हैपन. ओके, सो ये जो मिसअंडरस्टैंडिंग होती है उसके कारण एक तो हो सकता है कि पेशेंट कंप्लाई नहीं कर रहा है. सेकंड हो सकता है कि कोई जेन्युइन रीजन है, लाइक कॉन्स्टिपेशन कैन बी अ जेन्युइन रीजन, राइट, कि किसी को अगर वो दवाई लेने से कॉन्स्टिपेशन हो रहा है तो वो नहीं कंप्लाई करेगा उस दवाई के साथ. तो उस कंडीशन में यू कैन गो फॉर 2 थिंग्स, आइदर यू रिजॉल्व दैट प्रॉब्लम, या तो मैं उसको बोलूँ, मैं उसको कॉन्स्टिपेशन के लिए सिरप टिमाफिन ऐड कर दूं, है ना, सो दैट आपका कॉन्स्टिपेशन विल बी टेकन केयर ऑफ, बट यू प्लीज डोंट स्टॉप द ट्रीटमेंट बिकॉज that treatment is very important for you. तो आप ऐसा करो. Second can be that I can give them an alternative. तो अगर वो oral drug को comply नहीं कर रहे, so is there a parenteral option that I can give? Is there an IV option that I can shift to? It is sometimes I've seen कि just mentioning कि अगर आप oral नहीं लेंगे तो आपको injection लगाना पड़ेगा. Just the thought of that actually makes them more compliant to the treatment कि मुझे injection लेना पड़ेगा, है ना. तो it is better कि मैं दवाई लूँ, वो सही रहेगा, है ना. So even that strategy can work sometimes. So most of the times it is helpful if you try to understand the reason why they are not taking it, because what it can be just 3-4 things, right. या फिर वो भूल जाते हैं, उनको टाइमिंग ध्यान नहीं रहता है, या फिर इट कैन बी अबाउट द टेस्ट और इट कैन बी बिकॉज ऑफ सर्टेन साइड इफेक्ट्स. अदरवाइज व्हाई वुड यू नॉट टेक द मेडिकेशंस, राइट? सो ये चीजों को समझ के आइदर वी प्रोवाइड द अल्टरनेटिव or you give them a solution to their side effects, and most of the times again they will comply to the treatment. And if they do not, in some rare cases, then I think we need to accept some cases would not be in our hands. So yeah, we need to proceed. Yeah.
Thank you so much, sir, for sharing such a great knowledge with all of us. I hope that audience have learned a lot from this, and especially they will follow all the 6 steps of breaking bad news and your gather technique, which is, I think, is a very important part in our clinical practices. So, so here we come to an end of the workshop for day 1. We hope you all have heard carefully and learned from sir. On the behalf of IMA MSN UP, I would like to thank you, sir, to take out some time for the budding doctors and address them with such a valuable lesson. Now, our heartiest thanks to Dr. Ashok sir, Dr. Jayant sir, and Dr. Sharad sir. Without their guidance and support, this event is not even possible. Thank you so much, sir. Till the time your blessings are with us, we don't have anything to worry about. And thank you to the audience for their patient listening. Over to you, Megha ma'am.
Now it's time to call it for a day. I would like to mention the details about tomorrow's schedule quickly. Tomorrow, our panelist will be Dr. Ravikant Tiwari sir, and he will be speaking on how to write a good prescription and how to prescribe the lab tests. The event will be held from 7 p.m. to 8 p.m. Tomorrow, our moderators will be Abhinay Srivastav and Shashwat Sanket. Till then, have a great day ahead. Be safe. See you all tomorrow. Thank you.
Thank you so much.
Thank you.
Thank you, sir.
Thank you, sir.